Trials Unit at the University of York. This is the Research Room. Hello.
Hello.
Welcome back to the Research Room with me, Lucy Ather.
And me, Janine Healy.
And this week in the Research Room, we're really excited because we've got a dental project. We haven't talked about dentistry before, have we? No. So we've got with us Vicky Exley and Professor Zoe Marshman. Welcome to the Research Room.
Thank you. Thank you.
And you're going to tell us all about your project, which is called CALM. So could you just introduce yourselves for us?
Yep. So I'm Zoe Marshman, Professor of Dental Public Health from the University of Sheffield.
Hi, I'm Vicky. I'm a trial coordinator here at the York Trials Unit. I've worked here about 4.5 years now, and I've worked on quite a mixture of trials, but I've been with the CALM team about 3 years.
Great. Oh, well, thank you so much for coming into the Research Room. We're really looking forward to learning all about CALM. So could you tell us the long name of your project? So obviously it's called CALM, but that I assume stands for something.
Well, loosely stands for looking at the clinical and cost effectiveness of a guided self-help cognitive behavioural therapy intervention to reduce dental anxiety in children.
Wow, that's quite a long one.
It is a long one. So we knew we wanted to have an acronym, but it was quite important to get it right. So we did a lot of acronym generator exercises and lots of chats with our parents and young people who are part of our PPI group. So everybody was fairly happy with CALM. But it doesn't really relate to the title well.
Well, we do sort of you obviously know that we rate the acronym, a little short name. So
are we going to lose points for that?
Well, potentially. You like a nice acronym, don't you?
I do.
But it's a really nice name, isn't it?
It is.
I think it is a nice name. And you must have had a lot of thought to put CALM in. Is that why you said it, or to do revolving your PPI group and stuff?
Yeah.
Because the thing about it is we use the title as a shorthand amongst ourselves and the research team. But because we wanted to have it like a kind of a branding so that the young people that are taking part recognise it, the questionnaires and things like that as part of the trial, we needed it to be something that could be like written on a questionnaire, on a pen, on a highlighter, on some of the branded merchandise that if the dental practices who are involved are going to talk about it, they could talk about it between themselves without making anybody more anxious.
Yeah.
But definitely Vicky and I would say that there have been moments where it hasn't been calm. Where we've definitely perhaps questioned the choice of the acronym.
Yes.
But I think it wasn't a bad choice.
And I think because of the kind of target participants, it's a really nice name.
Well, I suppose we can rate it.
Yeah. I like the way... I think it fits really nicely.
Yeah.
With the trial. Yeah. Are you going to rate it out of 10?
Oh, I don't know. Because they're staring at me. I suppose I could give it a 7 because they put a lot of thought in it.
Yeah. I'm going to give it a 7.5 because I like the thought behind it, and I think it's quite important, the branding of a trial. I think people don't really think about it, but I really like it when a trial has a nice logo and a nice name.
We do have a really nice logo as well. It's
it is a lovely logo.
Yeah. So your logo it's a little tooth, isn't it? With some nice colours.
We have a few different versions because there was something from, again, lots of PPI work on this about people not wanting to see a smile where the teeth are all perfect, if they were a bit concerned about their own teeth, or a tooth that kind of looks too smiley, because if you're anxious, you don't want to be, think that perhaps you're different from everybody. So there was quite a lot of thought into making it a little bit dental, but not too dental, not too dentist colours, but calming. Yeah. So we had lots of discussions with the parents and mostly the children and young people. And this age, the sort of 8 to 16-year-olds, are a pretty tough age group to please sometimes. We're trying to please everybody. So it was a little bit of a compromise, but it's good.
Yeah,
I suppose
I like it.
We've done this rating of the acronym, and actually Well, I've never really thought before that it is a marketing tool, isn't it?
Yeah.
I've never thought of it as that.
Well, I think some trials think about it more than others. Some trials do have a kind of a nice logo and they've really thought about it, and then other trials...
Some are very random, aren't they?
Yeah, some are a bit more random and maybe they don't put as much thought into a logo or a name.
Yeah.
But I think it's quite interesting,
the
branding. And I want to do a spot on branding. A study within a trial.
Do a study within
See
a
if it makes a difference. Because I would rather join a trial that had a nice logo and a nice name. But maybe that's just me.
Yeah, could be. So in a nutshell, could you describe your project, what it's all about?
Yeah, so we've got lots of young people with tooth decay. We've got lots of young people who are anxious about dental treatment. And over the years, people have tried different ways of helping children to kind of get the dental treatment done. But then sort of more recently, people have borrowed from psychology some of the techniques, the sort of talking therapy type techniques like cognitive behavioural therapy. So we've been working in this field for a while to try and use a really low intensity light kind of CBT intervention to see if we could actually reduce the dental anxiety, and then trying to compare it in this study to what's the kind of usual approach, which is just to try and help the children manage their behaviour a bit. So it's really trying to think what's better. Is it the usual care, which is essentially the dental team just trying their usual techniques, and we're comparing that to this light, low intensity self-help kind of cognitive behavioural therapy approach, and then looking at whether over a year the dental anxiety that the children report themselves actually reduces. So it's the first time it's been done, and it's really important to us to do it in primary dental care. So that's like high street dental practices.
Oh, okay.
Because that's where most of the children with dental anxiety are first seen.
Yeah, yeah.
They might then, lots of them have to go on and have sedation or general anaesthetics if they're really anxious.
And that's in a hospital rather than your dentist.
A hospital or like a specialist clinic. So it's all based in primary dental care and involving the children themselves principally, but also having parents as participants as well.
Yeah, yeah. So it's all children who are a bit scared of the dentist, very anxious about the treatment, and trying to help them be less anxious, I suppose, yeah.
But to see if it does help.
Yeah,
because you could presume that it helps, but that's why we need to evaluate it, to test whether it really does help or not.
Yeah, yeah.
So is this CBT, that cognitive behavioural therapy that you're looking at, is it different to, you say it's the light touch, so what exactly is that?
Yeah, so CBT can be delivered in lots of different formats. So you could have where you have a therapist delivering the CBT face-to-face over a number of sessions. You can have group-based therapy sessions. But this is low intensity because it's a self-help guide. So it's like a bunch of resources that are developed based on the cognitive behavioural therapy theory. And essentially the dental professional would introduce the guide to the children and parents, and then point out some of the relevant activities. Then the children and parents take it home, have the opportunity to look at it at home. There's a message to dentist. There's a sort of form that they can complete, that they can bring with them to their appointment, and then kind of work through that as part of the course of treatment. So it's part of the course of treatment. So it's not something separate that the children and parents do with a psychologist or anything like that.
Okay.
So it's just integrating it as part of the treatment.
Yeah. And is it sort of delivered, I guess, rather than by a psychologist? Would the dentist or dental nurse, they would give you this?
Yeah.
Okay.
So it's the value of that is because if you keep it separate, if you see a separate psychologist or a therapist, when you get to the bit where you have to really have the dental treatment done, that perhaps the dentist or dental professional that be doing the treatment, if they don't know about the techniques you're using, they can't necessarily help the young person use the technique. So the idea is, and there's not enough psychologists to go round to be able to have it delivered in any other format, really. So So the value of this is that with a very little bit of training, the dental professionals can deliver it and they can integrate it into their usual care. And then they can help the child through the treatment because they know what activities or techniques they're using. But it's never been tested on this kind of scale before. So part of the trial is to look at what the children and young people, the parents and the dental professionals think of it when they actually use it like a day-to-day technique.
Yeah. Oh, so it's like sort of extra support really from your dentist. And did they get it before they go to the dentist? Or is it when you turn up for your appointment, you'll be given the kind of support then?
Yeah, so as part of the trial, because of the trial techniques, the trial procedures, they had to be given it after they were randomised.
Oh, yeah.
But probably if it was done outside of a trial, it would ideally be better to give it as early as possible.
Yeah.
But because of the trial procedures, they have to have the baseline questionnaires and then they have to be randomised.
Oh, yeah, of course.
So it's a little bit later than you would like in an ideal setting.
But they have to do it that way to find out if it's made any difference, don't they?
Yeah.
You have to have the before and after they've given the treatment.
Yeah.
So can you tell us a bit more about why you're doing this project?
So for children that have dental anxiety, if they have tooth decay, it has more of an impact on them because they've got the tooth that's hurting, so they've got toothache, perhaps difficulty eating. They know they're going to have to go to the dentist and have some treatment done. It makes them not want to go. It makes them want to put it off. Yeah. So that means they've got toothache for longer. Perhaps they're finding that they're making excuses to the parents when the parents are trying to take them. So then we know that those children end up having worse kind of oral health quality of life. They've got more teeth that are decayed that aren't filled. They're probably more likely to have the teeth taken out when they could have been saved. And then if they don't get any help and the teeth need to be extracted rather than treated earlier, then those extractions often have to be done in a hospital or sedation with a specialist. So then they're on a waiting list and they're travelling to a clinic or a hospital to have it done, and longer waiting times, longer travelling times. And there's thousands of children every year that have to have hospital admissions, general anaesthetics for teeth out. Yeah. So the consequences of having tooth decay and dental anxiety are quite severe for the child, for the dental services, for the NHS, because it's really costly to provide this kind of specialist treatment. So there really hasn't been anything new in this field for decades. So it's just about trying this new sort of psychology-based approach to see if it can reduce anxiety, reduce the reliance on the specialist care, reduce the need for general anaesthetics, but to get the treatments completed kind of quickly and in the primary care, the dental practice setting.
Yeah.
Is it a big problem then? Is it the anxiety amongst children?
Yeah. So we've got about, it's like 1 in 5 children have, 1 in 5 children of this like 8 to 16-year-old age group who have anxiety that's bad enough to really impact on their, their visiting to the dentist. Yeah.
Wow, yeah, that's loads, 1 in 5.
That is a lot.
Yeah. And then I suppose, obviously we want them to be able to be treated at the dentist and not have to go to hospital and be put under general anaesthetic and everything.
Yeah.
Yeah.
Is there a reason why, or is it just prevalent, it just happens?
Yeah, I think there's not many people that like going to the dentist.
Yeah.
Obviously I do.
I quite like going to the dentist.
No, I used to when I was younger, but I don't like now. I don't. Yeah.
So it's quite a common fear, and probably not helped by the fact that, if people talk about the dentist, it's always talking about it in generally negative terms.
Yeah.
People, perhaps young people, if they hear their parents or their friends talk about going, they're influenced by that. Maybe they've had a bad experience themselves. There's lots of different causes of dental anxiety. And we don't really dwell on that in the project, but it's just about how to help reduce it.
Yeah.
And then for this age group, it's really about helping them reduce it and manage their own anxiety so that they can cope when they get into adulthood, because a lot of the specialist services that maybe are available for children are not available for adults.
Oh, yeah.
So longer term, we want them to have like the skills they can they can use, they can draw on for themselves to be able to cope.
Yeah, because if you're scared as a child of going to the dentist, you're going to be as an adult. Is there a reason why you picked 9 to 16?
Yeah, so cognitive behavioural therapy, because it's got the cognitive bit, which is thoughts, you can really only sort of alter your own thinking when you get to a sort of stage of child development. So it does vary very much between children.
Yeah.
But they sort of say that the CBT experts, and that's not me, but the child psychology support that we had when we were designing the trial would suggest that really from 8 years, you're able to sort of think things through and perhaps alter the way you think about things, and then that helps you alter the way you behave. And
yeah, because cognitive behavioural therapy, we've talked about it a little bit before on the podcast, I think, in our BART episode. That was CBT. And it's all about kind of reframing your thought processes, isn't it?
So that's why we go down to 8. For younger children, if you were a young child and you had 3 decayed teeth, say you were 5 or 6, it's almost inevitable that you're going to have to go and have those teeth out. They're usually baby teeth.
Yeah.
Probably would end up having a general anaesthetic for those. But as you get older, it's permanent teeth. The sort of hospital admissions tend not to be like an available treatment is quite the same way for the older child. So we really need them to be able to kind of get to a stage where they can manage their own anxiety enough to get the treatment done.
Yeah. And if you were sort of supposed to have the treatment at the dentist, but you were the child was really scared and they did have to go to hospital, would you be waiting a lot longer for that?
Yeah, definitely.
That must be bad for your tooth if you're then having to wait longer to treat it.
Yeah, and then you have to wait for longer. You have to get used to a new dentist. Perhaps you're seeing a specialist they're brilliant, but it's a new setup, it's a new chair and a new clinic or whatever to get used to. Assessment appointments and getting, further down the line with the treatment. So generally you have to wait quite a lot of time, and they might be waiting in pain.
Yeah. And I think I read that, correct me if this is wrong, that the most common reason for admissions to hospital for children is dental issues, which that surprised me. I didn't realise.
It is surprising that, isn't it?
Yeah. So obviously it's quite a big problem.
That's for like children that are 5 to 9.
Is it? Okay.
So the most common reasons for hospital admissions for that age group, and that's for children that have got dental decay related extractions. So it is a really, really big problem. Some of that is to do with anxiety.
Yeah.
Some of that is just, as I said, because if you've got a severe dental decay, those hospital admissions are kind of inevitable, really.
Yeah, sometimes you really have to go to hospital. Yeah.
But there's the whole other podcast about preventing tooth decay. But that's not for today.
Yeah.
Said like a true dentist.
Yeah, because you're a dentist yourself, aren't you? Yeah. Oh, brilliant. And so you're doing your Project Calm is a randomized control trial, which we like at the Trials Unit.
Of course, yeah.
The gold standard of research, of course.
It is, yeah.
So could you tell us a bit more about how the project works?
So we've got the sort of dental team and we've got the psychology input, but the Trials Unit provide a lot of the trial management, statistics, health economics side. So that's where Vicky and Liz come in.
Your bit. We're looking at you, Vicky.
Vicky, this is yours.
Time to shine.
Okay, so we're involved in more of the day-to-day running of the trial. Yeah. So we liaise with our dental sites about their paperwork, getting paperwork back to us, chasing up paperwork as well. Yeah. And we've finished recruitment now. So
great.
We at the moment we're just in the last few months of follow-up. So we're just trying to get those last few questionnaires back in.
And how many people have you recruited?
Well, our target was 460 and we got 467 in the end.
Oh, wow.
So
over target.
A few extras. Well done.
Yeah. That's quite a lot. How long were you doing it for, recruiting for?
When did we start? May 22.
Oh, right.
We did have a year extension to meet the target. I think it was quite interesting working with dental practices, dental sites. Yeah. It was new to me. And it's a bit different to how we normally do things. Like when we're dealing with NHS trusts, we deal a lot with research nurses.
Yeah.
Whereas in this trial, we've been dealing with primary care dental sites. So it's often very, very busy dental practices we're deeling with. So
I bet.
And often they've not been really involved very much in research, if at all. So it was new to them as well. So it's a learning curve for everyone. But we've had some really great sites, and we found that a lot of the sites that had got involvement from their dental nurses or even their practice manager, they worked really well together, and that was really good.
How many different dental practices were involved?
We were aiming for 30.
Oh wow, that's a lot.
But we ended up with 40.
Oh my goodness, 40!
Wow, and is that all over the UK or England or?
We worked in specific regions, so we've got 5 regions, and we had clinical leads in each of those regions, and 1 or 2 research nurses also with that region, so they could help kind of do more hands-on stuff with the setup, and if the sites needed, they could go into the practice and help. And we were also aiming for 80% of our sites to have a postcode in kind of the highest areas of social deprivation as well. And
that's good.
I think we finished on about 89.
Wow, God, you keep exceeding your targets, don't you?
Yeah, because those children, the children in the most deprived areas are the ones that are most likely to have tooth decay.
Yeah.
So there's kind of no point trying to pick out the children that perhaps don't have as much tooth decay because they're not, perhaps have the same potential to benefit.
Yeah.
So that bringing in our research inclusivity in our recruitment. Yeah.
So the children come into the trial and then they're put into either your kind of special CBT group or the usual care.
Yeah.
And then I'm assuming there's lots of questionnaires, which there usually is.
Yes, so we have questionnaires at baseline, I think Zoe mentioned before, and then we do some more questionnaires at the end of their course of treatment.
Okay.
And then our primary outcome is actually at 12 months following randomisation, so they do some more questionnaires at that point.
And when you say the primary outcome, so that's the main thing you're looking at. And what is that?
It's the MCDAS, Modified Child Dental Anxiety Score.
Right.
So okay. And I'm assuming that measures anxiety levels. Is it specifically dental anxiety levels?
Yeah. So specific questions about procedures at the dentist that they might be a bit scared about. So hopefully we'll be able to measure any difference between those that have had the CBT intervention and those that have had the usual care.
Yeah. And are you measuring anything else? So sort of quality of life, things
We've
like
got
that?
Quite a few secondary outcomes. We do the child health related quality of life and oral health related quality of life. They're both at the end of the course of treatment and at 12 months again. We also measure the dental anxiety of the parent or carer with the modified dental anxiety scale again. And we're also measuring how many appointments they attend or miss. I think that's for the health economics.
Yeah.
And then we're also measuring if they need to be referred on to secondary care or for use of sedation or anaesthetic.
Yeah, so you can see whether that comes down or not. Yeah. And how did you find recruitment? Were people quite happy to be involved?
Most trials, we struggled a little bit.
Yeah, it's always the thing that's the most difficult.
We were quite steady, weren't we? But it was lower than we originally anticipated. That's why we had the extra sites. We went from the 30 to the 40.
Okay.
I see.
Yeah.
Just weren't being greedy.
And we also struggled a little bit with retention. So that was our main issue initially.
And that's getting people to fill in those questionnaires and to not leave the study.
So the questionnaire at the end of the course of treatment, we always had good return rates for, but it was the second lot of questionnaires at the one year point that we were struggling with. And of course, that, as we said, that's our primary outcome. So we had to work quite hard at improving that. Initially, we were around the 40% mark, which is quite low, but we've managed to get that up to around the 70% mark. So we're really pleased with that.
Yeah. Was there a reason you went for 12 months? Is that just because you want to make sure they're it's a lasting effect?
Yeah. I think what you can see in the literature certainly is that when you start dental treatment, you might be quite nervous, but when you get to the end of it, you sort of a sense of relief. You think, phew, that's it. It's done now for the next however many months.
Yeah.
So if we'd have just relied on that, I think it would have been quite difficult to have really meaningfully captured a difference. Whereas 1 year later, that's more heading towards the longer term benefits potentially, and whether the children really have developed the skills that they need to be able to cope longer term with having dental treatment done. So it was quite ambitious, but hopefully it will mean that we can capture a bit of that long term as well, particularly now we've got a good retention rate.
Oh, that's good. And a lot of these questionnaires are for children, aren't they?
Yeah.
So a lot of the questionnaires will be done for children.
Yeah.
How does that differ working with children in research than adults?
Well, we've tried to keep the questionnaire to a minimum, really, so we're not overburdening them. And we also we try to get the questionnaires completed at the dental practice with the dentist there, so and their parent, of course, so to help them if they need that help.
Yeah, because it must be a bit different. I wonder if you have to like word things differently even in the questionnaire.
Yeah, I mean they are validated questionnaires, so we haven't made them up. Somebody else has made them up and tested them.
Yes,
but then when we decided which ones to include, we put them together, and then we got some of our youth forum members, so our PPI members, just to check that they flowed well into each other and they didn't take too long and they weren't too repetitive. And it was something that they would be able to complete in just a few minutes while they were sat in the waiting room.
Yeah.
They get one of our branded pens.
Oh, very nice.
And then at the end of the follow-up, they get a £10 shopping voucher to say thank you to them for their time.
And that's after did you say it was 12 months,
yes,
the main one?
Yeah.
Okay.
And of course you mentioned the PPI group, the patient and public involvement, so they're quite important, aren't they, with these trials?
They've been really important all the way along. So we've got young people, the youth forum, we've got a parent panel, and then our independent trial group. So again, they're the kind of voice of reason all the way along to make sure that we do everything we can to kind of capture their perspectives right throughout the trial.
And they come to our trial steering committee meetings as well.
Oh, great. Really helpful to have that input. Definitely.
Very important.
Yeah. We like PPI members.
We do. We love PPI members.
So did you mention you were doing some economic analysis as well? What does that involve?
Yes. So one of the things that we're looking at is the cost effectiveness.
Yeah.
So that's whether, so comparing again, we've got the usual care and this new CBT intervention. So it's sort of trying to capture, so if there is a difference in terms of how effective they are, what does that look like in terms of costs that might be for the NHS? It might be for patients, like things like travelling backwards and forwards to the dental practice, or parents taking time off work, or children taking time off school.
Yeah.
And then also how that relates to any improvements in the child's quality of life. So Trials Unit is leading that and helps to try and take all the data from the children, the data from the dental practices, from the parents, to try and come up with a kind of magic number at the end about whether it really is cost effective.
Yeah.
But there's a lot, like the things we've talked about hospital admissions, which are expensive, travelling, missing time off school, which is really important for children. There's a lot of those factors. It's kind of cost, but there's lots of other things that go into it as well.
Yeah. Yeah. It's always really interesting, the cost effectiveness analysis, because you're not necessarily always looking to kind of save money, but you do want to make sure that if the thing that you're testing, you get good results and it works, you want to make sure that it is also cost effective and it's not going to be really, really expensive to do.
It's really expensive. You can't you can't advocate that you're going to use it.
Yeah.
And there's some really interesting things about like time, because it takes a bit longer in the appointments to use this intervention. But then perhaps it saves the appointments where, the child is really distressed and the dentist doesn't get any of the treatment done.
Oh, yeah.
Which then is perhaps not best use of the time.
Yeah.
Or it could be that it helps save those missed appointments that Vicky mentioned. So we're capturing that to see whether how many there's differences in how many appointments are missed because the children are trying to avoid going. So there's lots of sort of interesting things in the health economics that it's quite tricky to capture them, but really important to try.
To try is the main thing, isn't it?
Yeah. No, it's a really interesting element of it. And are you also doing any qualitative work? Quite often there's some qual work in there.
So we've got the trial and then we've got an embedded process evaluation. So that's mixed method. So all that means is we've got some quantitative data. So that's some other questionnaire type data.
Numbers.
And then the other bit of the mixed methods is the qualitative. So that's the interviews and focus groups. So that's been trying to look at things like how acceptable is this new intervention for the dental professionals that are using it, for the children and the parents. So we've actually already done that bit and got that bit finished and published.
Oh, great.
So again, it's really important because that will help when we get the outcomes of the trial.
Yes.
To help to kind of like interpret what those mean.
Yeah, definitely. It's really good to put them together and then you get a more full picture. Great.
Yeah. So overall, it did seem like it was acceptable to those different groups, but like the children, they thought it was useful, but sometimes it's difficult for them to find the time because some of it kind of relies on them perhaps looking at it at home.
Oh, yeah.
And then also some of the children, might find it quite difficult to talk about things that are really, the things that make them really anxious. They definitely don't always feel comfortable talking to dental professionals, but perhaps the message to dentist, is something that might help that. So that was interesting to hear from their perspective. And again, the parents thought it was quite useful for them because they don't always know how to help their children. They talk about like doing the bad cop, the good cop. They'll talk about shouting. They'll talk about bribing.
Yeah.
They'll talk about having to like try and like advocate for their child and speak up to the dentist. So this kind of gives them a little bit more of a structure to that.
Yeah.
And again, the dental professionals, they like to have something extra they could use, but some of them already thought they were pretty good.
Yeah.
Helping the anxious patients. So really interesting, generally very positive. But again, we need to try and integrate that findings into the findings from the trial itself.
Yeah. It'd be really interesting to put them all together at the end.
Yeah.
Oh, well, we can put a link to the qualitative paper in the show notes if you want to read more.
Yeah.
You can check that out. So what's next for the project?
Yeah, so we've got to this stage now where we're thinking ahead to how to share the findings of the trial. We want to make sure that we share that with obviously the dental practices, the patients and parents that have taken part, but also with a wider group of dental professionals who might be the ones that will be, deciding whether to deliver their usual treatment or perhaps to adopt this new approach depending on the findings. But also to try and work with some of the commissioners of dental services and the policymakers, the people that are developing the guidelines. So that's the clinical guidance that the dental professionals use. So a kind of a range of different ways of thinking about how best to share the findings so that when we get the findings, we can make sure that we get the messages about what the trial.
You'll be ready when you have those results.
So it'll be probably a combination of like the traditional papers and sharing details on the website, a bit of social media.
Yeah.
We're also trying to work with the dental professionals to see whether they want to come to us and have like a little mini conference about it, or whether they'd prefer to have it online, like a webinar, to share the findings. So we're at that sort of stage where we're trying to work out the best way of doing that now.
Yeah. And coming back on the research room.
Oh, of course, yeah.
To tell us all about your findings. Oh, great. Well, I think the next thing we'll do is we'll grab the hat.
I think so, yes.
We've got some random research questions for you that we'll pull out of the hat.
Here we are. I've pulled them all out. Just pull one at a time. Shall I? Okay. I'll do one then.
You go first, yeah.
Would you rather have to present your research findings entirely in rhyme or using interpretive dance?
Good question.
I'm going rhyme.
Yeah, I think I agree.
Ooh, yeah. Another type of dissemination you can add to your list?
Yes.
Interpretive rhyme.
Yes, quite short rhyme. But if you can't sum it up in a short, succinct way, then maybe that is good. It could be the way forward. Summing it up in a very short poem.
Yeah.
That'd be quite good, actually.
I think it would be good. I feel like there's lots of good words that would rhyme with like tooth and dentist. What dentist?
Well, I don't think anything will rhyme with dentist, but
I think there's scope for a very good rhyme there.
Yes, definitely.
Seriously, you could get your PPI. Because you say you've got children on it, didn't you?
Yeah.
To come up with
especially for kids.
Yeah, either actually you could do it the rhyme would be a bit better, wouldn't it? Interpretive dance.
Yeah.
I'll look forward to hearing the calm rhyme.
Yeah. Or a rap.
A
rap might be good, yeah. You're down with the kids.
Oh dear, not sure. My children would agree with that.
Okay. What's one thing you wish you had more time to spend on?
I suppose we did a lot of the PPI work, really in-depth work at the start. And perhaps over the last year or so, because we've been in this follow-up phase, we haven't perhaps done as much. And I guess what we don't want to do is leave it right to the end, because to carry on the kind of theme of involving the children and parents, we're going to really need their help, again, helping us to interpret it and helping us to know how best to share the findings. So I think I'd probably like a little bit more time to do that. But sometimes all the trial procedures and all the busyness with all the paperwork kind of gets in the way a little bit. So I definitely need to make sure we leave some time for that. But again, the timing is tricky because we're going to be at the end. It's going to be really busy. So I think perhaps a bit of more dedicated time. But we have got a team.
Yeah.
So one of our colleagues, Jenny, she from Sheffield Hallam University, she's done a lot of this work with us before. So we'll enlist Jenny's help for that, I think.
Look out, Jenny. Vicky?
Maybe a bit more time at the end as well, so we can. It all moves very quick at the end. So some time then would be good.
What is the nerdiest thing you do? Shall we ask you first, Vicky? I don't know why I did that.
Because the trials you did.
Because we just immediately look at me. I'm a bit of a jigsaw fan.
Oh,
it's a bit nerdy. A lot of my friends make fun of me.
Oh, what's the number of pieces you go for? Do you do like a 1,000,000-piece jigsaw?
No, I'm not that bad. Tend to be about 1,000.
1,000 pieces. Oh, very good.
Very little, those 1,000 pieces, aren't they?
Yeah.
Yeah. I'm trying to imagine what a 1,000-piece jigsaw is. Is that really difficult?
That's just a standard one.
Is it? Okay.
Well, it's 500.
500 or 1,000.
Yeah, 500 or 1,000.
Oh, I do like jigsaw. Very relaxing.
My friend recently, for my birthday actually, she just bought me it's like a micro Lego thing as well that you make an orchid with. That's very cool.
Yeah, I love those.
They are, yeah.
Oh, I don't know what that is. What's that?
It's like Lego for grown-ups.
Yeah.
I love that.
And it's like flowers, isn't it? Yeah, nice.
Then you've still got my son's Lego, so you could still use that.
You could use that.
I'm not quite sure. Nerdy. I think there's different definitions. Probably gardening.
Oh, okay.
Is my nerdiest, but I don't even know whether gardening is nerdy.
Don't know.
Yeah.
It's not really nerdy, is it? I would have said that gardening was nerdy. Gardening was nerdy.
I suppose how nerdy you are about gardening.
Well, yeah. Do you have to get up every single weed?
No. Maybe probably the most nerdy thing then is how much time I probably spend working.
Oh, yeah.
Yeah.
Yeah, that's quite nerdy.
Yeah. That is it then.
Yeah. Do you read a lot about dentistry in your free time?
Well,
it isn't free time. It's like work time spilling out.
Oh, yeah. Always thinking about teeth.
Yes.
You did say when you came in that you check people's teeth when you first meet them, don't you? Yeah. She's staring at our teeth now. I can
You're
tell.
a dental nerd.
Dental nerd.
Yeah, a tooth nerd.
Yeah,
a tooth nerd. what's your favourite way to unwind after a long day of research or dentisting?
Well, mostly I would say that this is where Helen Rod, who's one of the members of the research team, so she's a paediatric dentist on the team. So Helen and I like to run. So probably the best way would be for me to meet Helen in the Peak District. We'll have a run for an hour.
Nice.
Cup of tea and a scone, a little bit of a rant about work. Then we move on to our favourite other topics and then finish with a scone and a cup of tea. And that's, so that's a very nice bit of the sort of winding down from research. And
lots of scones really in there.
And lots of scones.
Running and scones.
Fresh scones.
Yeah.
Well, they have to be fresh scones.
Yeah,
that's
or
nice.
a tea cake if there's no fresh scones available.
Oh, yeah. Oh, it's nice being based in Sheffield. You're just
the hills,
District.
of course.
Nice.
Peak District,
yeah.
And Vicky, what do you do?
Well, I live at the coast, so I like to take my dogs down to the beach.
Oh, lovely. Nice.
Did you put that there?
No, I haven't done anything.
This is her favourite
I haven't engineered anything.
This is her favourite question, I think. What is your favourite... Sorry, start again. I've got to read it right.
Yeah.
What's your favourite part of your research?
I think apart from the running with scones bit, I do like the chatting with children because it never ceases to amaze me how good they are at telling us what not to do or giving new insights that we hadn't thought about. So that's the kind of the best like real life stuff where you're just talking to them about perhaps ideas for how they would design a project or little tips from them about how to make taking part in the project a bit more appealing. Sometimes they like our ideas, sometimes they don't. But
I bet they tell you as well.
Yes.
So that's that's probably the best.
Yeah,
the best bit.
Nice. That's nice.
I think what I like about research in general is, I guess when you're kind of a health professional, you see your patients and you see that you're helping them there and then. Whereas research, you're helping people on a wider scale, really. So at kind of policy level or healthcare changes. And I think that's really important.
Yeah,
it is.
Yeah, definitely. Yeah, helping people. Yeah. Well, that's why we do it, really.
It is. That's why we do. Helping people.
Yeah.
People and children now. Well, children are people.
Children are people.
Children are the future.
They are actually. Yeah, children are the future.
Oh well, thank you so much for coming into the research room today and telling us all about your project.
Thank you for having us.
You're very welcome. And we will hopefully love to have you back when you have some results.
Oh, yes, please come back. It's been really
interesting.
Yeah, it's really interesting.
Really interesting project. Yeah. And we haven't had a dental one before, so that was really, really nice.
It's good.
But just say thank you, really.
So you can learn more about the CALM project, and we'll put links in the show notes and the results of the paper that they mentioned and anything else. A link to their website.
Yeah, if you want to learn more.
If you want to learn more.
Bye. Don't forget to like and follow The Research Room wherever you get your podcasts. And if you'd like to leave us a review, that really helps other people find the podcast.
Does it?